afternoon. Today I'll be discussing a range of topics to expand your knowledge and help you prepare for your journey. I will begin by explaining how a new existence is created, transforming from cells to an embryo to a fetus before it enters the world as a new bundle of joy. Midway through the presentation, I will inform you about the typical healthcare processes that a pregnant patient encounters, including tests and scans as well as monitoring during pregnancy and labour. I'll also explain how monitoring can lead to interventions and changes in the birth plan. The last section covers chromosomal abnormalities, genetic disease screening and fetal anemia, followed by an in-depth talk about miscarriage and abortion. Following ovulation, the ovum, also known as the egg, rests in the fallopian tube where it is capable of fertilisation for 12 to 24 hours. During sexual intercourse, a single sperm out of 100 million penetrates and fertilises the ovum, merging its nucleus into the ovums to combine their genetic material to transform into a zygote. The zygote then becomes a morula, which travels down the fallopian tube to enter the uterus, where the cells continue dividing and become a blastocyst, which is a mass ball of cells that will become the fetus. With the help of surrounding trophoblast cells, the blastocyst finds the wall of the uterus, attaches to it and implants itself. This marks the beginning of pregnancy, which lasts 37 to 42 weeks. Following the first 2 weeks of pregnancy, the blastocyst is protected by surrounding amniotic sac fluid, which provides cushioning. The blastocyst requires nutrients for growth, which it receives from a tiny yolk sac called the umbilical vesicle. This is a temporary provider until the placenta forms. The blastocyst appearance changes rapidly and it performs spontaneous involuntary movements as it forms tissues, organs and the nervous system. By the end of week 3, future sensory foundations are laid and comprise touch, sight, hearing, taste and smell. And by the end of week 4, the blastocyst has transformed into a 2 mm long poppy seed sized embryo. Throughout weeks 5 to 8, the upper body growth rate exceeds the lower body, resulting in temporarily longer arms and legs and a large looking head. Although the senses are progressively developing, they are not ready to be used yet. At 6 weeks, the embryo begins producing a heartbeat, and by the end of week 8, the embryo transforms into a 16 mm long raspberry sized fetus. Throughout weeks 9 to 12, involuntary movements comprise head rotation, stretching, jaw movement, jaw opening and eye movement under closed eyelids. The end of trimester 1, which is week 12, brings many milestones. The face, palms and soles of the feet form touch receptors. The cartilage skeletal template has formed, as has the heart, which is now fully functioning with a stable beat that can be heard in an ultrasound scan. The organs making up the digestive system have formed, including fully functioning kidneys that allow swallowed amniotic fluid to pass through as urine. Furthermore, the placenta has formed and the fetus is now plum-sized, around 5.4 centimetres long. Week 13 brings formed ovaries or testes, followed by lanugo in week 15, a fine silky hair that covers the entire body. This is around the time the taste buds and hearing become functional, and listening consists of a muffled mother's digestive system, heart and voice. Week 17 brings unique fingerprints and an overall fetus size comparable to a pomegranate, around 12 centimetres long. The senses progress through weeks 18 to 22. Sucking reflexes and overall movement increase at 20 weeks, which can cause the mother to feel a fluttering sensation. Also during this productive week, the fetus becomes covered in vernix, a white hydrating film. At week 21, the limbs become proportional with the rest of the body, and by week 22, the fetus, which is now potato sized, is around 27.8 centimetres long and outweighs the placenta. By the end of trimester 2, at 27 weeks, hearing abilities have progressed, and loud noises can cause forceful movements, which are harmless but can be surprising to the mother. The eyes open for the first time, and although the lungs are still underdeveloped, breathing is practiced using placenta oxygen. The fetus is getting plumper daily, and it shows in its skin as the folds fill out with fat. At this point, the fetus size is comparable to a cauliflower, around 36.6 centimetres long. The third trimester begins with the heartbeat becoming strong enough to be heard through a stethoscope. At week 29, movements increase and can include kicking, punching, and somersaults. This is also the week that the vernix skin covering begins disappearing. At week 30, vision improves and eyes can focus. And by week 32, the liver is fully formed and functioning. The fetus is almost perfectly formed and is around 42.4 centimetres long. Week 33 marks the completion of the brain and nervous system, followed by increased sensory capability. By week 36, the lungs have matured sufficiently and are capable of breathing outside of the uterus. The end of week 37 brings new facial expressions, such as frowning and smiling. However, these triads are completely random and are not related to feelings. The bones strengthen, however, remain soft and flexible, and the digestive system contains meconium, a green substance that will form its very first stool. The fetus is now around 48.6 centimetres long, and it has developed enough to be titled full term. At this stage, weight gain becomes a priority. By week 40, all sensory capabilities are well developed, and coordination is being mastered in preparation for the first outside world interactions. As focus shifts to delivery preparation, it wiggles its way down and enters the pelvis, getting ready and comfortable for its big appearance. The ideal labour position is achieved when the head points down towards the mother's back. However, this step is sometimes delayed until labour begins. At this point, the fetus size resembles a pumpkin, around 51.2 centimetres long. The symphysis fundal height, also called SFH, is the distance from the mother's pubic bone to the top of the uterus, which is measured non-invasively using a measuring tape. It entails reclining the mother and pressing on her abdomen to measure her for a growth chart. Typically, this is tracked at each prenatal appointment from week 24. It is beneficial when tracking the fetus's growth and amniotic fluid volume to determine if there is normal under or oversupply. It also helps to identify macrosomia, which is when the fetus is larger than predicted for its development stage. However, measurements are compromised in pregnancies with multiple fetuses, as the uterus encounters rapid stretching, facilitating varying fetus sizes, growth rates, and positions. Measurements are also challenging in cases of obesity, as excess fat tissue can obscure the true uterine size. These factors enhance misinterpretation, making the pregnancies high risk. Thus, ultrasounds are preferred over standard fundal height measurements. Ultrasound imaging, also known as sonography, involves emitting high-frequency sound waves through a transducer, which is a probing tool, and through the skin, enabling them to bounce off the fetus and other internal structures and organs related to the fetus to deliver real-time images onto a monitor. External scans are recommended routinely throughout pregnancy, and internal scans are often reserved for in-depth examination as required. During an external scan, a gel is applied to the mother's abdominal skin surface, and a transducer is moved over and around it. It monitors the fetus's age, growth, size, heart rate, and position. It also monitors the placenta, and it can detect multiple pregnancies, abnormalities, and complications. During an internal scan, a gel is applied inside the vagina, where a transducer is inserted. This allows inspection of internal organs, cervical length and thickness, blood flow, excess fluid in the lower body, cysts, and ectopic pregnancy. Doppler is advanced ultrasound technology that is often reserved for high-risk pregnancies requiring extra monitoring. It is capable of measuring blood flow, contractions, and heart rate. Scanning one of the two mothers' umbilical arteries allows the measurement of the blood flow running from the umbilical cord to the placenta, and scanning her uterine arteries allows the measurement of the blood flow running from the placenta to the fetus, which is responsible for passing nutrients. Similar to an external ultrasound, a gel is placed on the abdomen where a transducer emits sound waves. In high-risk pregnancies, continual measurement of the fetus's heart rate and of the mother's uterine contractions are often obtained through a cardiotograph, which is conducted through Doppler. During labour, the midwife keeps track of the mother-fetal heart rate, temperature, blood pressure, urination, water content, contractions, and cervical dilation. In the first stage of labour, the fetus's heart rate is measured every 15 minutes, and in the second stage of labour, the fetus's heart rate is measured every 5 minutes or after each contraction. There are two key ways of doing this. Intermittent oscillation, also known as listening in, which involves listening to the heart using a non-electric hollow horn-shaped instrument called a Pinard stethoscope, which is lightly placed on and around the mother's abdomen. The Doppler ultrasound method electronically monitors the fetus's heart rate through sound waves that bounce off its heart to create audible sound and a visual display. Both methods are commonly used and pose no risk to pregnancy. A CTG is generally not required for healthy pregnancies that include a single fetus. It is primarily used in high-risk pregnancies and when concerns arise about the fetus's well-being. A pregnancy can be considered high risk for numerous reasons, which include multiple pregnancies such as twins or more, obesity, pre-existing health conditions like diabetes or high blood pressure, placenta issues, and a pregnancy history of stillbirth or miscarriage. A CTG can include electronic fetal monitoring, which measures the fetus's heartbeat through a transducer strapped on the mother's abdomen by a removable belt. It allows for charts showing the fetus's heart rate and contraction changes over time. A telemetry monitoring device, which also measures the fetus's heartbeat and the mother's uterus contractions. However, wirelessly, it is often offered to those requiring more movement during labour and is recommended to those using a birthing pool. A fetal scalp electrode monitoring device, which is placed inside the vagina, allowing attachment to the fetus's scalp. This is not normally used and is reserved for when external monitoring is unsuccessful, which can be for various reasons such as obesity, the fetus change in position, or excessive movement. An intrauterine pressure catheter. This involves a catheter being inserted into the uterus with a pressure transducer at its tip, allowing detection of any pressure changes during contractions. It directly measures the strength, frequency, and duration of the uterine contractions. It is not typically used and is reserved for when there are concerns regarding contractions. Monitoring allows a team of healthcare professionals to make more accurate decisions, prioritising safety in a timely manner. Therefore, it is essential for ensuring the mother and the fetus's health. Sometimes the findings from monitoring can lead to interventions and changes to the birth plan. If weak or irregular contractions are identified, the mother may be administered medication such as synthetic oxytocin, which is usually given in small doses to increase contraction intensity over time. If distress is identified in the fetus by a high or low heart rate, the mother's position may be changed and she may be administered oxygen. If these interventions show little or no improvement, immediate intervention may be required to speed up the delivery, such as an episiotomy, which is an incision made between the vagina and the rectum. The use of forceps or a vacuum device. If the fetus's body movements begin decreasing along with an irregular heartbeat, it could mean the fetus is not coping well with the vaginal birth and is lacking oxygen. In this situation, the birthing plan may change to a required emergency caesarean section. Caesarean sections are categorised from 1 to 4 based on urgency. Category 1 is the most urgent and life-threatening, and Category 4 is elective or planned and non-urgent. A Category 1 caesarean section generally comprises a 30-minute target to get the fetus out. However, it is often accomplished in 15 minutes. A chromosomal abnormality is caused by an abnormal number of chromosomes. An extra chromosome, also known as a full chromosome, a partial chromosome, or a missing chromosome. Normally, humans have 46 chromosomes altogether, and they are arranged into 23 pairs. If there is an extra copy of one of these chromosomes, trisomy occurs, which causes development and health problems for the growing fetus. Trisomy types are categorised by the specific chromosome number that has the additional copy. The most common are trisomy 21, which is Down syndrome, trisomy 18, which is Edwards syndrome, and trisomy 13, which is Foetal syndrome. These can be identified through screening, which is offered to all pregnant women using the NHS, typically between weeks 10 and 14 of pregnancy. Screening is also known as the combination test because it includes an ultrasound and blood test. First, the mother's blood is drawn and examined, followed by an ultrasound scan to measure the nuchal translucency, which is the fluid at the back of the fetus's neck. These findings, combined with the mother's age, determine the likelihood of the fetus having either of the three trisomies. Occasionally, the fetus's position restricts the nuchal translucency measurement. In this situation, further screening tests are offered later in pregnancy. A more definitive answer can be achieved from a chronic villus sampling, also called a CVS test, and an amniocentesis test, which are optional. They both involve a very fine needle being inserted through the abdomen. CVS is usually carried out between the 11th and 14th week of pregnancy and collects from the placenta, and an amniocentesis test is usually carried out between weeks 15 and 20 of pregnancy and collects from the fluid surrounding the fetus. Both of these tests should be carefully considered, as they carry a small risk of miscarriage. If the results conclude a chromosomal condition, the mother is given the options of continuing or terminating the pregnancy. Down syndrome is the most common of the three trisomies. Scotland's yearly statistics comprise 70 babies born with Down syndrome, 1 in 5,000 babies born with Edwards syndrome, and 1 in 1,600 babies born with Foetal syndrome. Genetic sickle cell disease is common among African and Caribbean people. The condition is caused by a mutation in the genes that regulate hemoglobin production. It's highly deadly, and if left undiagnosed or untreated, it can lead to major health issues. Common symptoms varying in severity include fever-like symptoms, anemia, yellowing or jaundiced skin, eyes and mouth caused by a substance, bilirubin, which is released following red blood cell death, sudden pain occurring anywhere in the body from blood flow, and stroke from a lack of oxygen to the brain. In the UK, all pregnant women and their partners are offered a simple blood test to detect the disease and other hemoglobin abnormalities. Pregnant women should ideally undergo this test before 10 weeks, which involves drawing blood typically from the arm. The fetus of a mother who is a carrier and a father who is not a carrier will not suffer sickle cell disease. However, there is a 1 in 2 chance it will be a carrier. The fetus of parents who are both carrying the disease comprise a 1 in 4 chance of being a carrier, a 1 in 4 chance of not being a carrier, and a 2 in 4 chance of becoming a carrier. Additional tests, known as diagnostic tests, are offered to the mother in the event that both parents are found to be carriers. These include the CVS and the amniocentesis test, which, as previously mentioned, carry the risk of miscarriage. Fetal anemia occurs from a lack of red blood cells in the fetus's blood. It's typically caused by genetics or isoimmunization, and it's dangerous because it increases the risk of fetal heart failure and labour complications. Isoimmunization is also called rhesus disease or hemolytic disease of the fetus. It is the incompatibility between the fetus's blood cells and the mother's blood cells. Since the fetus's immune system does not recognise the blood, it attacks it, resulting in a lack of supply, causing the fetus's heart to work overtime to compensate for its loss. If isoimmunization is found, an anti-D immunoglobulin injection is offered to the mother, which prevents the body from making harmful antibodies against the blood. Isoimmunization can be avoided if it is detected early through umbilical cord blood and maternal blood tests, which are usually referred to at antenatal checkups. It can also be detected other ways. These include using Doppler to check the blood flow rate and heart condition, sampling fetal blood with ultrasound guidance, and sampling amniotic fluid through an amniocentesis test. In order to treat fetal anemia, an intrauterine fetal transfusion is offered. This involves using ultrasound to help guide an injection into the umbilical cord to transfer red blood cells, usually O negative blood, in order to directly infuse the fetus. Due to the invasive nature of this procedure, risks such as premature birth and miscarriage increase. A miscarriage occurs when a fetus dies in the uterus before the 24th week of pregnancy. After this, it is called a stillbirth. Miscarriage is common. UK statistics show 10 to 20% of women miscarry in their first trimester and 3 to 4% in their second trimester. There are many miscarriage myths. Some common misconceptions include sex, spicy food, and air travel. There is no evidence suggesting sex is a direct cause of miscarriage. The vast majority of miscarriages occur from chromosomal abnormalities or other factors that are beyond the woman's control. Research suggests sex can actually offer multiple benefits, such as strengthening the immune system and improving pelvic floor strength, which helps in preparing for labour. Eating spicy food will not cause a miscarriage. It is considered safe, and the anti-inflammatory properties of some spicy foods can even enhance the immune system. Air travel is not harmful to pregnancy and is considered safe. Therefore, most airlines allow pregnant women to fly up to the 36th week of a single pregnancy. Risk factors of miscarriage include obesity, lifestyle choices, certain medical conditions like diabetes or thyroid problems, a history of miscarriages, and women conceiving beyond the age of 35, as there is a 20% risk of miscarriage at this age, which increases further over time. The majority of miscarriages cannot be prevented. However, there are some things that can be avoided to reduce the risk. These include a poor diet, smoking secondhand smoke, alcohol, and illegal drugs. Particular foods to avoid include all types of patty, including vegetarian, mold-ripened soft cheeses, and raw or impartially cooked meats and eggs. Caffeine should not exceed 200 milligrams, and medication that includes caffeine should be taken with caution in regard to this limit. There are various types of miscarriage. A missed miscarriage is when the fetus stops developing but remains in the body. There are usually no noticeable symptoms, therefore it is commonly identified through an ultrasound scan. The NHS offers several options to manage this, including expectant management, which is waiting for the tissue to pass naturally, medical management, or surgical management. A complete miscarriage is when the fetus, placenta, and other pregnancy tissues are entirely expelled from the uterus, leaving it empty. It typically requires no further management. An ectopic miscarriage is when a pregnancy that has formed outside of the uterus, usually in the fallopian tube, ends due to its inability to develop normally. Following this, expectant management is offered, which involves careful monitoring to see whether assistance is required to remove any pregnancy tissue. This can result in medical management with methotrexate or even surgical removal, which sometimes includes the fallopian tube. A molar miscarriage occurs when an abnormal egg or sperm fertilizes and implants in the uterus, where it transforms into a non-cancerous tumour that resembles a cluster of water-filled sacs. This inhibits the continuation of pregnancy. Management can include surgical methods such as suction to remove the abnormal tissue, followed by checkups, ensuring no further complications develop. Common signs of miscarriage include vaginal bleeding, unusual vaginal discharge, reduced morning sickness, and cramping. Miscarriage signs in later pregnancy can include a reduced feeling of movement in the abdomen and an early breakage of waters. After a miscarriage, menstruation typically returns to normal after 4 to 8 weeks, and many mothers continue to have normal, healthy pregnancies thereafter. Under the Abortion Act 1967, abortion is legal within the first 23 weeks and 6 days of pregnancy in Scotland, England, and Wales, comprising agreement from 2 doctors and the condition that surgical termination must take place in an NHS hospital or another government-approved facility. Beyond 23 weeks and 6 days, further criteria must be met in order to proceed. These include the pregnant person's life being threatened should the pregnancy continue, the pregnant person being at risk of physical or mental harm, or a severe abnormality found in the fetus. Some severe abnormalities include bilateral renal agenesis, which is the absence of kidneys, and anencephaly, which is the absence of a brain. There are 2 methods of termination. The medical termination method ends the pregnancy using medications such as mifepristone and misoprostol, which restrict the hormone progesterone. Firstly, mifepristone is administered, which is taken by mouth. 24 to 48 hours later, misoprostol is administered, which can be taken by mouth or inserted into the vagina. This causes the uterine lining to break down with accompanying symptoms of abdominal cramps and bleeding, signifying the end of pregnancy. The surgical termination method is usually offered 13 weeks of pregnancy. First, the patient receives an injection which stops the fetus's heartbeat. Next, the patient is administered medication which helps to open the cervix in preparation for operation. And 24 to 48 hours later, the patient is offered general anaesthesia of either deep sedation or conscious sedation to enable the operation to continue. The method used to remove the pregnancy and associated tissue depends on how far along the pregnancy is. Before 10 weeks of pregnancy, medical termination is viable and it can take place at home. Assistance in a clinical setting may be required beyond 10 weeks. After 13 weeks of pregnancy, surgical termination via vacuum aspiration is a viable method. It involves insertion of a small tube into the vagina and towards the cervix. It is usually completed within 5 to 10 minutes. After 14 weeks of pregnancy, surgical termination via dilation and vacuation is a viable method. It involves insertion of forceps into the cervix and towards the uterus. It is usually completed within 10 to 20 minutes. Heading into the end of trimester 2, medical termination followed by induced labour and birth is a viable method. This can be a very long process, lasting as long as natural labour and birth. Patient symptoms after an abortion beyond 13 weeks can include side effects from anaesthesia or sedatives, as well as stomach cramps, vaginal bleeding and nausea for up to 1 month. The loss of a pregnancy, whether through abortion or miscarriage, can be an emotionally and physically draining experience that can be accompanied by feelings of shock, guilt and anger. If you're suffering or have suffered the loss of a pregnancy, you must understand and remember that there are many people who want to listen to you, support you and offer you guidance through your grief and recovery. They can be found through NHS support services which can be sourced by recommendations from your GP or even a quick Google search. There are many charities offering support, some particularly for those who are experiencing or who have experienced a miscarriage include Miss, Sands and Tommy's. Charities for those who are thinking of, proceeding to have or have experienced an abortion include SI Reproductive Choices, formerly known as Marie Stopes, Abortion Support Network and Arch Trust. We have now covered fetal development up to 40 weeks, symphysis fundal height measurement, fetal monitoring through ultrasound and advanced ultrasound scanning, including a CTG, and how these can lead to interventions and changes in the birth plan. Furthermore, screening for chromosomal abnormalities and genetic diseases such as sickle cell disease has been highlighted and described in what they entail. Also, fetal anemia and treatment have been discussed. Miscarriage and termination have been covered, as well as coping with the loss of a pregnancy. I hope you have all found this presentation educational and informative. If you require further information on any of the topics discussed, or if you have any questions, please feel free to ask. If your question is private, please feel free to email me after the presentation and I will reply as quickly as possible.